There are 4 parathyroid glands located posteriorly to the thyroid gland. They have one job, which is to secrete parathyroid hormone. The only purpose of the parathyroid hormone, it's secreted in order to increase serum calcium levels. So this is just like the T3, T4, the release and control is controlled by the hypothalamus. Hypothalamus constantly monitors calcium levels in the blood. So when it sees it low, then it releases PTH. And the negative feedback mechanism is, of course, if the serum calcium levels are now high, it stops secreting the PTH. Okay, so that's how it works. Yeah, that sounds right. So these are their locations. So we're looking at the posterior aspect now. So in front, behind this is of course the neck. Okay, so we're looking at this from the back of the head. So that's how the parathyroid glands are situated. So as you can see, their blood supply is from the thyroid glands themselves. So if we have removal of the thyroid gland, then that means we end up removing the parathyroid glands as well. So what will lead to hypo and hyperparathyroidism? So similar causes. So we have the most common cause is a tumor growing on one or more parathyroid glands. It doesn't have to grow on all 4. One tumor on one parathyroid gland is already enough to cause either hyper or hypoparathyroidism. Let's look at the first problem first. Let's go hyper. But this is quite simple because what's the purpose again of PTH, parathyroid hormone? Okay, no.
Calcium.
To increase serum calcium levels. How does that happen? It will cause calcium to be broken down from the bone. Remember, 99% of our calcium is in our teeth and in the bone. Only 1% of our serum calcium is in the blood. So at any given time, there's only a specific amount of calcium between 9 and 10 is the normal levels in the bloodstream. So whenever we need more, we simply take it from the bone. So primary is the most common type. It's very common in people who are older people, and those also with kidney disease. Remember chronic kidney disease and ESKD? Okay, so most people on dialysis have bone problems. This is one of them. So they'll have hyperparathyroidism, or sometimes they can also have hypoparathyroidism. Manifestations are manifestations of what? What's the main problem of this patient? They have what? They have low or high? They have very high calcium. Remember, this is hyperparathyroidism. So what happens to their PTH levels? Very high. So therefore, what happens to the calcium levels? Very high. So manifestations are therefore signs and symptoms of what? Hypercalcemia. That's it. So this is a very short topic. What are therefore signs and symptoms of hypercalcemia? So apathy, fatigue, muscle weakness, nausea, vomiting, constipation. And there will be cardiac arrhythmias that may occur. What else are consequences of high serum calcium? Can you have kidney stones?
Yes.
Okay, you can have kidney stones. And where did this calcium come from again? So therefore, what happens to the bone?
It weakens.
Okay, weakens the bone, puts the patient at risk for fractures. All right, yeah, injury and fractures. So they'll develop skeletal pain, tenderness, joint pain, pain on which bones are weight-bearing? Long bones, so leg and thigh bones, and also the pelvis, right? So all your weight-bearing bones will bear the brunt of the pain. let's go now to how do we manage it? Patient has, what's the most common form again? Primary or secondary?
Primary.
Primary. And what's the cause of the primary? Okay, so therefore, what's the treatment? Surgery. Okay. So parathyroidectomy will be performed either partial or total parathyroidectomy. And since, where is this located again? Behind the thyroid gland. So therefore, what will happen to the patient? Will it also affect the thyroid gland? Yes. Will the pre and post-op be different?
No.
It'll be the same.
Oh, I
okay?
just meant from the thyroid.
Yeah, so hyperparathyroidism. If we opt for parathyroidectomy, then the pre and post-op care is exactly the same as thyroidectomy. Okay, so I need to repeat that.
Yeah, one time.
Which part?
So.
The thyroidectomy, the pre and post-op? Yeah, simply read back to the other chapter.
The post-op pre-op.
Yeah, it's exactly the same.
I thought you meant repeat what you just said.
Oh,
That's what I'm saying, yes.
yeah, so you remove the,
When you say it, it sticks in my head better. Because I'll remember your voice saying it.
it'll also be the same thing if you read, if you listen to last week's lecture. Exactly the same.
No, I just want you to say what you just said. So when you do the
What?
parathyroidectomy,
Parathyroidectomy, yeah.
the post-op and the pre-op is the same as just doing a thyroidectomy. That's what
Exactly
you're
the same,
saying.
because
Okay.
what are you removing?
The thyroid.
You're also removing the thyroid, because can you just excise, because remember, there's a tumor. Okay, it's not like you're just removing the parathyroid gland. Okay, there's a tumor on it, so therefore, you end up taking out the thyroid gland. So that's why the pre and post-op is exactly the same, because can you just remove the tumor and the parathyroid gland without removing the thyroid gland?
No.
No. So that's what I mean by it's exactly the same.
Okay.
Now, until the patient has surgery, now we have to manage the hypercalcemia, correct? Because we just can't decide, okay, let's do surgery right now. No, we have to prepare the patient, remember? So just like in hyperthyroidism, we did not do surgery right away, correct? Yeah, we gave them the, what was given to the pre-op patient for iodine preparations, right? We gave PTU or methimazole, right? So there's preparation. Plus, we gave them a high protein diet, right? High calorie diet. And then we we also treated them symptomatically. Remember, we gave propranolol, etc. So here, same thing. We will have to manage the hypercalcemia condition because we can't just do surgery right away. So what is the treatment, therefore, for hypercalcemia? First choice is hydration. Lots of fluids. Can you drink fluids nonstop by mouth?
No.
Can we give it IV? Yes. Okay, so IV fluids is the main treatment. Of course, we also encourage the patient to drink PO, but again, you get bloated, right? Because water has, or anything you eat has to sit in the stomach. It's not like going straight into the intestines and out the back door. Okay, so it will sit in the stomach, so there's a limit to how much PO intake we can take. However, not for IV hydration. So we give IV hydration. What this does is it dilutes the bloodstream, so causes dilutional hypocalcemia. However, this is not the only treatment. Once we give the fluids, we will also give the patient diuretics at the same time. Okay, so this will facilitate removal of calcium from the body. So this intervention will limit the complications. It will limit the kidney stones from forming. So this will prevent serious dysrhythmias caused by the hypercalcemia. However, not all kinds of diuretics are used. What does it say here? Okay, thiazide diuretics are avoid. Why? Okay, will actually increase calcium because this one will preserve calcium in the kidneys. So we'll use what therefore can we use? What diuretic? Loop can be used. So not thiazide. For mobility, remember what are they at risk for? fractures, right? So they have weakening of the bone. So what does that mean? What activity do we prescribe?
Weight bearing. Right?
Bed rest or ambulation? Why ambulation? That's correct. Okay, so the more you stress the bone, then the stronger it will get. Okay, of course, you still institute fall precautions because, of course, these patients are weak, but we don't want them to be on bed rest because that will actually worsen the condition. It will actually increase the calcium even more if you put the patient on bed rest. All right. We can give phosphate or phosphorus. Why again? So just like sodium potassium, which has an inverse relationship, what is the relationship between phosphorus and calcium?
Calcium high, phosphate is.
Also inverse, right? Okay, so we give them oral phosphates. However, if it's severe hypercalcemia, phosphorus can be given IV. Okay? For acute severe hypercalcemia. For diet, what type of diet do we give? The patient has low calcium in the bone, a lot in the blood. So what do we do?
High fiber.
So what does it say here?
Avoid that.
Okay, so we do not restrict the calcium, but we also do not give excess calcium. So regular diet. Okay, remember, is this because they took too much calcium in the diet? That's why the calcium increased. Why did the calcium increase here? Okay, it's the parathyroid hormone, right? So that's what we want to control, not the diet. So diet would be just like normal. Okay, we don't have to increase or restrict calcium in the diet. Because there's constipation, remember? One of the symptoms is constipation. So we give a high fiber, prune juice, etc. So they're all listed here. Okay, I'll skip over the surgery because we already did that in thyroidectomy. And these are your teachings. So until the patient undergoes parathyroidectomy, then patient has we all we can do are these supportive treatment. So activity, fall precautions, regular diet, increased fluids. What else? Diuretics, right? Okay, fluids and diuretics. Don't forget hypercalcemia. We will have many more conditions resulting in hypercalcemia, but what will the therapy be different? Will the therapy be different for any hypercalcemia? Every hypercalcemia patient will be treated the same way, but are they treated with surgery all the time? No, only this one because this is caused by the hyperparathyroidism. Okay, very good, Shu. Let's look at hypercalcemic crisis. So this is an emergency. So we kind of mentioned about IV phosphorus earlier. So that would be one of the treatment. If it's not severely high, we can get away with PO phosphorus. But since this is now a crisis, so the interventions again are a lot of fluids. We want to increase the renal excretion, so therefore we need to monitor urine output. Is the patient urinating a lot? Okay, because that's the only way the calcium will be removed. Because do we still give the diuretics here? Yes. Okay, so we still have loop diuretics. Why not thiazide again? Okay, so it will actually cause calcium to be reabsorbed. All right. And during this therapy, because this is involving liters and liters of fluid, so watch for fluid overload. We may overdo it. For drug therapy, they will be given bisphosphonates. You remember these from osteoporosis?
Yes.
Give me a drug that is a biphosphonate. What do they end with? You remember? dronates, right? Yeah, so we have alendronate, by ibandronate, right? Right. So those were Topamax and anyway, so just stick with generic names. They all end dronates. What is your teaching with dronates, with biphosphonates? When is it administered? What time? First thing in the morning. And what do you have them do after taking the pill? For how long?
30 to 60.
At least 30 minutes. And drink it with how much? A full glass of water. So 8 ounces or 240 cc's of water. Why do we have them sit up? Because the drug book said so? Why? Patient will ask, why do I have to stand? Why do I have to sit up? I want to go back to sleep. I can't sleep sitting up. Because the drug book said so. Is that your answer? What do you say? What was the rationale? So what are we trying to prevent? Why do they have to sit up?
No,
Okay, so if the drug goes back into the esophagus, what will happen? Not really choking. It will cause esophagitis. Okay, so it will cause erosion of the esophagus. Okay, so the drug is dangerous. So they have to sit up straight. Okay, so explain that to the patient. That way the patient knows why, they see it's scary, right? I mean, esophagitis that can cause ulceration of your esophagus. Now, every time you swallow, there's pain. All right, so whenever we have high or low potassium levels, high and low calcium levels, priority is, besides airway, the patient must be on a cardiac monitor. Very good. Other drugs used include calcitonin and steroids. Remember calcitonin? This is the hormone secreted by the thyroid gland to do what? To the calcium? Okay, very good. So this is the counterpart of the parathyroid hormone. Okay. So this will do the opposite. So instead of parathyroid hormone breaking down calcium from the bone, what will calcitonin do? Okay, go do the opposite. So here are your biphosphonates. So they all end in dronates, right? All right, that's it. Questions on hyper? Okay, let's go straight to hypo, and then we'll take a break. Hypoparathyroidism. This is now a deficiency of the parathyroid hormone. So the problem here will be low calcium. All right. So it's either caused by, can this result from treating hyperparathyroidism?
Yeah.
What do we call that again? If that's the cause? Iatrogenic. Very good. Or this could be from, can this also be from treatment of thyroid hyperthyroidism? Yes. Okay, so radiation treatment or surgery, right? Okay, for treating hyperthyroidism. Other problems are a vitamin D deficiency. This can also cause hypoparathyroidism. Manifestations will be those of hypo or hypercalcemia? Hypocalcemia. You still remember? We talked about hypocalcemia in hyperthyroidism treatment. So after surgery, what were those two very common manifestation again? Okay, Churrostics and Trousseau. Very good. And here are the others. So besides Churrostics and Trousseau, we've got the dysphagia, photophobia, dysrhythmias again, and seizures. So therefore, what is one of your interventions Very important interventions for people with hypocalcemia. You institute what? Seizure precautions. Talking about seizure precautions, what does that include? You can just say, put a sign there, seizure precautions. Is that enough?
No.
Okay, so what do you set up in the room? Oxygen, what else? Suction, what else? In a tracheostomy tray, what else?
The padding around the bed,
Padding,
having the bed low.
and yeah, and then what's the, give me one more. Because look at the interventions. So when we get to the interventions, what do we treat severe hypocalcemia with? Okay, we need an IV access. That's part of your seizure precautions. Because when they have a seizure, can you stop the seizure without medication?
No,
Can you give oral medication?
no.
No. Okay. So don't forget, IV access is part of your seizure precautions. All right, so now we have a low calcium. So earlier we had high calcium. Now we got low. So how do we treat it? They're low. How did you treat hypothyroidism? What did you give them?
We will give them
We gave levothyroxine. So here, what do we give? Calcium. What else do we give besides calcium? Okay, always give calcium
Do
with
you give
vitamin
phosphorus
D.
as well?
Well,
Phosphorus?
what do you think?
Because if the calcium is low, the phosphorus will be high, so no, you don't give phosphorus.
All right. So we gave phosphorus in hyperparathyroidism. Okay, so we give calcium. So how much calcium? Okay, we'll get to the dose shortly. Let's just finish this part. That way we don't forget. So we got calcium. Calcium can be calcium gluconate, calcium chloride. Magnesium is also given because hypomagnesemia can also cause hypocalcemia. Now, ergocalciferol or calcitriol, this is vitamin D. Okay. It's or because ergocalciferol is active. No, this is inactive. This is inactive vitamin D. So this is the pill. Calcitriol is activated vitamin D. The difference between the two, remember you were told at some point to get sun exposure. Why again? Okay, to synthesize vitamin D, right? So what they're talking about is ergocalciferol. Okay, so that's found in your skin. It's also found in your liver, in your lungs. So we need to activate it. All right, so ergocalciferol again is an inactive form of vitamin D. So that still needs to be activated, but our body can do that. Then we've got thiazide diuretics. Remember what did we not give in hyper? Okay, we gave loop, right? So here we can give thiazide because what will thiazide do? Cause the kidneys to reabsorb calcium. So this will be this will do the opposite of loop diuretics. Okay. What else do we give? Okay, so if this is if the cause was from thyroidectomy, then what did we give? IV calcium gluconate. Okay, so it's an emergency. Tetany is an emergency. And again, seizure precautions. If the patient does have seizures, and it's status epilepticus, meaning a seizure lasting more than 5 minutes, or if they have multiple seizures within 30 minutes of each one, then we don't give phenobarbital actually. It's actually diazepam, which is Valium, or lorazepam, which is Ativan. Anyway, we'll discuss seizures in module 10, I think. All right, diet. So what diet do we promote? Patient has low calcium.
High calcium. And
Okay, let's finish this sentence. So do we encourage this?
No.
Why?
so they have high level of phosphorus.
Okay, they also have high phosphorus. So what are our options instead? So we can't give milk and dairy products, including eggs. So what do we give them? Empanada?
Vitamins.
Can we give tofu? Yeah, that's non-dairy, right?
Yeah.
Yeah, but who likes tofu?
Nobody.
I do.
Nobody here.
Okay, so anything but milk and dairy products, okay? And we give sardines. Sardines are good.
Yeah.
Yeah, they have high calcium. So spinach also avoided.
So you could get tofu, sardines, and anything else with high calcium.
Yeah, and then vegetables also. Green leafy vegetables are high in calcium.
So what are they supposed to eat? What would be that?
High calcium, except like you can give meat. Meat is
Mm-hmm.
high in calcium.
Yeah.
Okay, but no milk and dairy products. So the yogurt, that kind of stuff are high in
Calcium.
phosphorus. Yeah, they're high in calcium, but they have phosphorus also. So it's kind of counterproductive. All right, so don't forget the safety, which is you institute seizure precautions. Do we also add fall precautions here?
Yeah.
Same, yeah. So both in hyper and hypocalcemia, the patient is at risk for falls and fractures. And here's your teaching. That's it.